Good afternoon, everyone. Welcome to the Enhancing Clinical Practice and Outcome stream of the SNOMED CT Expo 2023. My name is Jane Miller, and I work in the clinical engagement and collaboration teams at SNOMED International, and I'm moderating this afternoon's session. It may not be afternoon for anyone online, but welcome to everybody to this session. All questions will be answered at the conclusion of the presentation. Online attendees, please can you put questions in the Q&A box, and we will take those at the end and I'll read them out. And those of you who are here, I will be running around with the microphone. Unless, does that one in the middle work? Yeah, oh, there's one in the middle, so you can grab that as well. Okay, so let's start off this afternoon. No sleeping after your lunch, please. And I'm now very, very pleased to introduce Tina Papoutsakis. Thank you. From the Academy of Nutrition and Dietetics, who's going to be presenting the global journey of nutrition care process terminology, and representing it in SNOMED CT. Tina, over to you.
Thank you, Jane. It's so good to be here, everyone. And I wanted to mention very quickly my disclosures. I work for the Academy of Nutrition and Dietetics, and I also chair the SNOMED Nutrition and Dietetics CRG. I will be discussing today the experiences that we've had in collaborating with SNOMED to be able to represent nutrition terminology. And I'll be going into important background as well as key milestones in our pathway, our progress, our outputs, as well as our deliverables and plans for the future. I really like this heat map that you see on the slide I'm showing right now. And it shows how many dietitians around the world currently use the NCPT, which is the terminology that dietitians in many countries use to document care as an interface terminology. This has been possible because national dietetic associations have stepped up to translate the terms of the nutrition care process. For a deep dive in the NCPT and the translation process, please refer to the two published papers that I have cited. It's important to mention the Dietetic Association in Sweden has been in the forefront of translations, and they've published their work to help others. And that is a theme with this work. The backbone of our profession is the nutrition care process terminology. And we use the nutrition care process terminology to document the care that's provided. We've worked with SNOMED to enter the 2020 edition. And with the common goal of a terminology for the profession, many dietetic associations have teamed up with the Academy of Nutrition and Dietetics to develop and maintain content. So that has been a labor of love and volunteer work for many dietitians around the world. Another major motivation, besides being able to have terms to document specifically what dietitians offer in their nutrition care, is to study the related outcomes. And this has been possible with a registry platform the Academy maintains. I will talk about the registry a bit later on. I want to stay on the theme of dietetic associations teaming up, and with the leadership of Dr. Elin Lovestam at the University of Uppsala, we've been able to create a consortium that is called the ENIS Consortium, the International Nutrition Care Process Implementation Survey. And with that effort, we've been working to understand the implementation progress of the NCP around the world. We've done an initial data collection in 2017. This resulted in about 4 publications where we present our findings. And in that first round, we were able to show with dietitians participating in this survey, where the sample was around 10,000 or so around the world, that significant enablers that predict implementation are factors like the support by the professional body, peer support, and use of an electronic health record. And this is just a highlight of different findings that we've been able to reveal. We've just completed data collection for the second round of ENIS, and we have now 23 countries that are part of the consortium in the second round. We are really optimistic that we will be able to report in the near future changes compared to the baseline data collection, but also describe what is happening now. And it's really been very fruitful to have these active networks of collaboration among associations. This is why we're here today talking about nutrition care terminology in SNOMED. Back in 2012, there was work that was happening at the Academy in collaboration with different national dietetic associations. And originally, we were able to add, first in the US extension, a collection of terms, but it became very apparent very quickly that other countries wanted to see those terms in SNOMED International. So we had a series of meetings with SNOMED staff and key players who were engaged in this process. Some were NRC contact staff that were part of discussions. And soon after a meeting in Bratislava with myself and all these key people, we were able to progress to the formation of the NCPT CPG. Like I said, the main objective was to submit the NCPT into SNOMED International. And sometime later, there was also a formalized agreement between the Academy and SNOMED. Recently, the project group concluded its objectives that we will be going over together. And a COG was formed that will be addressing nutrition and dietetic content in SNOMED as a standing group. So in a nutshell, this has been our chronological pathway into time. So where are we now? There's a matched coded SNOMED term for data tracking in EHRs for the majority of NCP terms. But let us backtrack to talk about how did we get there. When I look at this slide that I'm showing you right now, I take pause because it shows all the work that we did in the past 5 years in this one slide, where first we engaged in a quality assurance project of the US extension terms that were then promoted in SNOMED International. We conducted a gap analysis that showed us we still had over 1,000 terms to enter into SNOMED. The CPG agreed to do a modeling pilot using 4 case studies, and we were able to identify about 100 concepts that would serve as the pilot to model and see how that goes. That led to developing 3 templates that helped us progress much more efficiently with the submission of our content. And at the end of the rainbow, there's a ref set, a simple ref set that, all going well, will be released in April of 2024. Next, I will highlight some of the work accomplished as broad themes that describe what kind of work happened. The group was able to implement improvements to SNOMED CT. As an example here, you see the concept of inadequate dietary intake of iron, which was revised more appropriately to inadequate intake of iron with a new parent of inadequate mineral intake. And that's the revised term or concept, rather. We also added nutrition content, and this slide is very rich. It goes over some of the areas that we were able to address. For example, there were substance modifications that helped model concepts that we needed to submit to SNOMED. For example, vitamin A was exclusively defined as retinol, and the preformed vitamin A, which is primarily from animal sources such as dairy products, fish and meat, was not included. Also, provitamin A, carotenoids that come from plant sources was not represented, and we were able to include vitamin A and vitamin A derivatives as an alternate. Fortunately, as we were adding content, there was a concurrent project on the substance hierarchy, and that resulted in us being able to add other substances that we also needed. We were able to add units of measure that were very critical in describing growth type of terms that we needed. And we think that these additions are not useful only to dietitians, but other healthcare professionals at large. Also worth mentioning is the discussion that we had on comparative standards for nutrient requirements and weight and growth goals, such as target body weight. And this is an ongoing conversation. I mentioned the 3 templates, and these are the ones that we came up with, one on nutrition observables, on nutrition findings, and on modified substance diets. We did this because we wanted to support consistent authoring and also support quality assurance through template compliance, and the work paid off. We were very happy with that process. An example of a modified substance diet is on the next slide, decreased cholesterol diet, which is a regime therapy. That's what most of our nutrition intervention terms are, regime therapies. And it's really interesting. We did this work with our regime therapy terms, but we were able to identify new projects along the way. And hopefully in the near future, when we go into reorganizing the regime therapy on dietary, on modified diets, we will have new opportunities to perhaps make some of these primitive concepts fully defined. So another terminology highlight that I want to share with you is different opportunities that we had along the way to support very important work that is interdisciplinary. We were very fortunate to be able to contribute to the Gravity Project, which is an HL7 accelerator project on social determinants of health. And our work focused on one of the 3 arms of the project, only the food insecurity. We spent about a year working on food insecurity as a term itself to define it, and also coming up with supporting intervention terms that then had the opportunity to go into SNOMED International in part and in other parts in the U.S. Extension with the support of the U.S. Extension staff, specifically John Snyder, who's been a big part of this work. And the IDDSI framework, this is the collection of the dysphagia terms. We were very happy to be able to support the conversations that led to the inclusion of those terms into SNOMED International, given that over 50 countries utilize the IDDSI framework. Even though it's a very small number of terms, it was a big deal to have these included in SNOMED, and we were very happy to help with that as best as we could. We also added terms on areas that helped better define care around malnutrition, so scores of validated nutrition assessment tools, as well as nutrition indicators for malnutrition. And that was the series of things that we were able to address as a CPG. In the course of our work, as I said earlier, we were able to identify different projects that were out of scope for the CPG. So we were compiling a list of projects, and all of these will become the work of the Standing Nutrition and Dietetics CRG. We have monthly meetings. Everyone is welcome. We would welcome everybody's participation. We're looking for subject matter experts in adult and pediatric nutrition for the projects we will be undertaking in the near future. And the group met in September. It identified its next project, which will be the reorganization of the feeding and dietary regime sub-hierarchy. So the contribution of experts is really very important. I mentioned the release of the reference set this coming April. This will include nutrition findings on the first round, and going forward, we are looking to include what we call nutrition interventions, but are the regime therapy type terms of NCPT. And these discussions for an implementation guide on the horizon. So those are some of the key areas that we're looking to tackle going into the future for nutrition care. Why do we do all this? We are very interested in collecting structured data to demonstrate the efficacy of nutrition outcomes. We've been doing this since 2014. We've compiled data from dietitians that enter their nutrition care in a registry that the Academy maintains. And recently we were able to analyze using machine learning analyses in a joint study with IBM Watson. Some of the key findings were very interesting, and without really going in deep to the details of that work, we were able to identify phenotypes of nutrition care. We were able to demonstrate that nutrition counseling is a predictor for the resolution of nutrition problems. What we're looking at here is another major line of research that we are engaged in. It's the Essential Connections Study. And this has been funded by the U.S. government, the Administration of Community Living, where we are building a FHIR API. I'm so happy to hear about FHIR APIs this morning, because this was my closing point, so it comes to full circle. What we're trying to do here is be able to make ND interoperable so we can increase referrals for patients who are discharged from the hospital with malnutrition, and connect them with dietitians in the community so they can receive nutrition interventions once they leave the hospital. You can see some of the outcomes that we're going to track are very relevant to the social determinants of health, and we're very excited to be able to report on what we find in the near future. So I will stop here for questions and comments and discussion. And before we go to that, I would be remiss if I don't thank all the staff and the volunteer leaders who've been part of this work, especially Donna Bertel, John Snyder, and everybody on SNOMED staff has been extremely helpful. Thank you.
Thank you, Tina. Thank you very much. Now, yes, questions if you have any, and a reminder for those who are online to stick them in the chat in the Q&A box. And if anyone in the room, either I'll come or there's a speaker in the thing. John.
Just a quick comment. I just want to thank Kathy Richardson also for the help on the Gravity project. I couldn't have done it without her help.
Thank you. Everyone's thanking everybody. It's been a team effort. It really has. Thank you. Are there any questions? Oh, well, Tina, I think the key thing there's nothing online. I would just add is I think it's really good news that we're moving now to the RefSet stage, so that people can easily get hold of this stuff, have a look at it, and develop some sort of guidance on using it. And Tina and myself and the implementation team have got a discussion about it today. We're not pressurizing her, of course, but it's certainly we've been putting together. If those of you who have been in clinical sessions, we talked about we're trying to develop information guides that are clinically focused, but it is technical as well. We're sticking that in as well, but we make it clear that this is primarily clinical with some of the technical examples. So it's very exciting development. Do you want to go to the?
Hi, my name is Mona. I'm from Norway. We have just implemented EPIC across the specialty and municipality care, and the SNOMED. We use SNOMED for all the diagnosis and medical data. And it was very early on a question about the nutrition RefSet for nutrition. And so this is really, really good news. The bad news is that our clinicians are not that happy with the new EHR system. They have to get used to using SNOMED as a clinical documentation terminology. And what we looked at when we were going to actually try and get those tools into the system for nutrition, it wasn't that easy to see how could we actually weave this in to a clinical practice. And I would love to hear more about that next year. And in 2025, how are we actually implementing this into clinical system and getting the clinicians to use it? And yeah, that was more a comment.
I think given the discussion we had earlier this morning about ICN and ICNP, I think we've got a bit of a trailblazer there that, you know, if we can start, that's where we can be a hub to share this stuff. Well, that's one of the reasons why Tina has agreed to continue to chair the nutrition care clinical reference group, is because that's an ideal point to share it. Just as we've got a very successful nursing group, this is about sharing and you shouting at what we and we can work on what you need and want, and also what you're learning. And these implementation guides we see as iterative, and you know, and just as Tina is being quite careful with the RefSet, you know, let's get started on it and then move it forward as people think. So that's ideal. And if you can show them something that they know by looking at a RefSet as a starting point, at least they start to have some trust in the content. So, yeah, thank you.
And I would add specifically for Norway and any country really, involve the Dietetic Association leadership early in the game, I would think that is important. Our contacts with the Dietetic Association in Norway are excellent. If you need any contacts and referrals, I'd be very happy to help you with that. I know I work with Lenny Torrison as well as Sissy Stove-Warrenson, who are both very active in this work and are actually part of the CRG. So making those connections, involve the professionals early on is what I would highly recommend.
Other comments? No, I'm having my throat cut at the back. So I thank you very, very much, Tina. And I think you'll all agree this is now, she's done a huge amount of work, but now the exciting bit comes, it's coming to you guys. So watch out. So thank you, Tina.